We know it's an explicit intent of government to move care into the community and into primary care. And as GPs, we're experiencing this firsthand. The problem is that much of this care is being transferred without due planning, with an expectation for it just to be absorbed by GPs and primary care, and without resourcing and an infrastructure to allow that to happen. And we believe it's patients who are being shortchanged in this. And what we really need is to do this properly, but also to make sure that patients who are seen in the community are seen for the right reasons, not financial reasons, and patients who are appropriate to be managed in the community.
What is that like from the patient's perspective then?
I think a lot of patients feel, for example, they're discharged far too early from hospitals. They then, are really transferred from a hospital bed into a bed in the bedroom without the full facilities and aftercare that they actually need. We see lots of patients being discharged, they tell me, from a hospital clinic where they would have liked a follow-up, but there's a lot of pressure not to follow up. And in doing so, often GPs are not given the facilities, tools, etc. to look after them properly. So I think patients are not happy with being moved into the community in a premature sense. I think if we're to do this, it has to be for the right reasons and in a planned, structured and resourced approach.
The motion that was passed was expressly concerned about the lack of resources that were following the patient out to primary care. What is the effect on GPs?
Well, first of all, we see patients in 10 minutes. It's simply impossible in 10 minutes to take a history, listen to the patient, empathise, to prescribe, to investigate, to explain a treatment, 10 minutes. And then on top of that, have to actually chase up a hospital investigation that the GP is being asked to look into, to start new treatments because the patient's not going to be followed up in clinic, or to actually answer a query about a knee operation they had 2 weeks ago because there's no follow-up appointment for that patient because it's moved into the community. It's just not possible. Now, what we know is that this is a major issue for GPs. There were 29 motions at the LMC conference stating that this was unsustainable. On top of that, we conducted a survey, the BMA conducted a survey last year of GPs nationally. There were 19,000 responses, more than the response for the pension ballot, in which GPs report, 2/3 reported considerable work-related stress, and 90% reported, an increase in the intensity of consultations. I think it's not just the numbers of patients we're seeing, it's the complexity, the exhausting nature of trying to do so much in a very limited 10-minute interval, and then to repeat it 20 times over in a whole morning surgery. It really is, I don't believe this is right for patients, not right for GPs either.
Gordon, is this something that you and your secondary care colleagues are concerned about as well?
Oh, very much so, because we in hospitals are under great pressure firstly to discharge patients as quickly as possible. Why? Because we are often on black alert, which means that there are just no beds left in the hospital. And so we're desperate to try to prevent unnecessary admissions and also get patients out as soon as possible. But as my GP colleague has just said, the resources just aren't out there. And although we are getting community geriatricians, looking after older people is much more than just having doctors out there. It's having a whole team of people, physios, occupational therapists, social workers, community psychiatric nurses, district nurses, community matrons, it goes on. And that infrastructure in most parts of the country just is not in place.
So is there a sense then that you're not providing optimum care for your patients by sending them back to the generalists?
It's not so much being sent back to the generalists, because the generalists can, which are the GPs, some, in fact, GPs have a special interest and have a diploma in geriatric medicine, for example, but many don't, and obviously they need access to geriatricians and the rest of the team.
Is there money, are there resources in secondary care though that are going to be able to follow the patient back to primary care?
Unfortunately not. That is the problem. I mean, we've had a steady increase of about 6% in admissions every year for many years now, and the money has not followed that.
So where do you expect the resources to come from, Chaand?
Well, I think there's a considerable amount of resources that are wasted in actually separating secondary care and primary care. If you look at the area of older patients, I mean, it's a nonsense to consider a GP as a purchaser and a hospital provider as a provider. We actually are in it together. We're both actually doctors on the same side. And what I think we should be doing is getting rid of this artificial barrier and this financial transaction that has polarized incentives and perverse perverse incentives, and we really need to be looking at a collective resource that brings together not just doctors in secondary care and primary care, but also the community resource of nurses, physiotherapists, community matrons and others. And I believe that by actually doing that, you would actually strip a layer of bureaucracy that would be moved into patient care. That's what the BMA has been arguing for. I think this is a very unintelligent way to run a health service, to actually create this division across a primary secondary care interface.
Chaand Nagpaul and Gordon Campbell, thank you very much.